Rahman Rahim. Good morning, ladies and gentlemen. It really gives me a great pleasure to be with you today. And I would like to thank the organizing committee for giving me the chance to talk with you in this fascinating symposium. Today I'm going to talk to you about our small subject on ATP1A2 gene. And let me see. Yeah. Let's start. Bismillah ar-Rahman ar-Rahim. In the name of God, the most beneficent. What I'm going to talk about ATP1A2, that and my scheme will be trying to introduce the gene for you first and told you my aim, what is our case report, the result, and then the conclusion. So, ladies and gentlemen, let me introduce to you ATP1A2 gene. That it's located in chromosome 1q23, and it's encoded for alpha-2 subunit in the plasma membrane of sodium-potassium pump. And for those who can remember it, this pump is so important because it will facilitate and control sodium and potassium in and out of the cells, and each of function, and this function is so important. Any abnormality here will cause major disaster sometimes, which I will show you. The problem with this gene that it's expanding, the mutation of it has expanding clinical feature. At beginning, they thought it's responsible for familial hemiplegic migraine and then alternating hemiplegic migraine. And today I'm going to show you how the phenotype is still expanding. The clinical spectrum, as I told you, it is first familial hemiplegic migraine. It's isolated or associated with benign familial infantile convulsion. And this is important because, you know, those who's working with the pediatric and even later in adulthood, we are facing a lot of patients coming with migraine and, coming with seizure. Sometimes with cerebellar abnormality, this seizure continues to become epilepsy and with mental abnormality. The other spectrum is alternating hemiplegia. So it's only that the patient will come with alternating of episode of hemiparesis. Also, before we know that distinguish between those two, the familial hemiplegic membrane and the alternating hemiplegia, that the first one, the alternating hemiplegia, will be with infantile onset of the characteristic symptoms, the alternating. And it has high prevalence with neurological deficit that become increasingly obvious with age, as I will show you also later. The alternating hemiplegic migraine is responsible, most of it, they have the gene in ATP1A3 actually. So what was our objective? That we will present the clinical and molecular data of Saudi family with novel ATP1A2 gene, and we would like to do some characterization of the distinct clinical phenotype associated with this gene. And there is another object, actually I just wrote it yesterday, because another objective and another aim, as I saw that there's a lot of junior and medical students here. There is a poem and a شاعر who said أهيم بدعد ما حييت وإن أمت أوكل بدعد من يهيم بها بعدي. And that's what he's saying, that he loved Da'ad, his a lady, and he would love her as long as he's alive, and when he would die, he will find somebody to take care of her and love her. And I guess why I put this, that most of people here, they love their career, they love genetic, metabolic, and we would like also the junior to become with us because we need it in our country, we need it in our region. We have a lot of patients, a lot of hope, and a lot of facilities that we need to be continued after us. So this is just فاصل ونواصل. So let's start our case report. My patient was a 4-year-old girl. She won 4 term spontaneous vertex delivery. She was hypotonic at birth. For this, they refer her to our clinic. It was a special clinic in military hospital that we are following the birth defect patient, starting to make, hopefully, registry, a small registry and then national registry. So she was hypotonic at birth, and this later on, at the age of 5 months, she had developed her first seizure. This seizure was becoming more and more severe and more recurrent and associated with mainly triggered by fever. Later on, she had attack of at 20 months of age, she had left-sided of hemiplegia. This hemiplegia was sudden, and then it's regressed slowly, improved. After 1 month of improvement, she had another attack on the right side. In examining her, she was well-looking child, not dysmorphic. Her vital sign was all fine, and her growth parameter was fine. Her neurological examination also only showed some hemiparesis at the affected site. Investigation, we did MRI brain twice at the beginning and at 4th year of age, and it was normal. We did EEG, full metabolic workup, including tandem MS, urine GCMS, lactate, ammonia, very long-chain fatty acid, biotinidase, and it was normal. And as you know, any recurrent hemiparesis, we think also of mitochondrial, and we send the mitochondrial DNA common mutation, deletion, screening point mutation, all were negative. Karyotype, ophthalmologic examination, all were negative. So our neurologist, brilliant neurologist, I have to say, he thought because of this alternating, why not to send for ATP1A2 gene? And we sent it by Cynthia, and it showed novel mutation. So the mutation was heterozygous, and one chromosome only was identified, and this position is located in a large intracellular loop and has a high degree of conservation among alpha subunit in several species, and this is the snapshot of the gene location. This variation was not evident in any of the 400 control in the lab they compared. So after we know that this patient, where is my mouse? Yes. I'm using this just because so everyone can see it. This is the patient, and we examined the father. The father was completely asymptomatic. When examined the father, he was positive, and he carried the same mutation. The mother was negative. The two sisters were negative. So we have now the father who is positive and he carried a mutation, heterozygous mutation, causing a recurrent hemiplegia in his girl, but he had nothing, and the other were fine. The patient was started in flunarizine, which is a non-selective calcium channel blocker, and this will control the sodium ATPase pump, and her hemiplegia were stopped. I mean, the attacks, they didn't recur. Follow-up for her, she showed slow improvement of her milestone. Hearing evaluation showed bilateral sensory neural hearing loss later on, but no more attacks, which was good information for us and good news. Coming back to family history, and this is a problem sometimes in our region, at the beginning they told you we didn't have anything, and when you specifically ask every person in the family history, did he have anything or not? So when I asked the father specifically when they come to my clinic, how is your sister's brother? She say, oh, I have one sister. How is she? She's 35 years old, but she had mild developmental delay and right hemiplegia. That's at age of 5 years, she started to have the first attack of hemiplegia. After 3 months, she had seizure, another attack. She was away from Riyadh, so we couldn't bring her to test her, but he told us that she had MRI brain showed ischemic result. So now we know that this is affected, this auntie and the girl. So what we are going to do now, we'll discuss some entity in this one. The ATP1A2 was identified as a gene associated with familial hemiplegic migraine, since 2003. The mutation and deficiency in ATP1A2 that cause familial are responsible for approximately 20% of the familial hemiplegic migraine. Just to make sure, just to repeat something, that this auntie and our girl had never had migraine. We identified a novel heterozygous mutation in ATP1A2 gene, causing atypical alternating hemiplegia of childhood in non-consanguineous family. The father was asymptomatic, and when you see, before I told you the father had phenotypically he's free, but genotypically he was affected. But at the beginning, if you have a family pedigree that the patient had a new mutation, which is autosomal dominant, a new disease, and the father is free, that you will think of a new mutation. Of course, not like this, but something like a new mutation. But this father had the positive, and he had the gene. So we think that it is loss of low penetrance, as the doctor yesterday was talking to us about penetrance. So this gene has low penetrance. From this report and previous report, we would like to do something. We can define a subgroup of children with ATP1A2 mutation with a clinically distinct phenotype. The most important 7 thing, it is familial, late age of presentation of the attack, occur of hemiplegic, and associated with intellectual disability that was not there before. It is common epileptic seizure, mainly triggered by fever, no history of headache. All of the previous clinical phenotype associated with headache except in our patient, and sensory neural hearing loss, which was also not reported before. This clinical feature clearly distinguishes this phenotype from alternating hemiplegia of childhood and familial hemiplegic migraine. Also, we have to make sure, because it has increased risk of ischemic stroke in our patient. Why? Because this gene mutation results in degeneration of the amygdala and piriform cortex, and failure of the sodium-potassium ATPase is involved in ischemic brain injury as a cause because of the glutamatergic excitotoxicity. And also there is increased risk of sensory hearing neural loss. So if you have any patient with those two phenotype, you have to check for this gene. So the recognition of this distinct clinical phenotype is important because it allows rapid genetic diagnosis and genetic counsel and treatment. So my take-home message, number 1, we have to recognize this new distinct clinical phenotype, direct genetic testing if you want it, because there is no enzymatic so far. So we just go direct to screen this gene. And later on, if it's fine, you have to counsel the parent, risk of stroke and risk of sensory neural hearing loss. Actually, this was accepted in Journal of Childhood Neurology, and I would like to thank Dr. Ibrahim Tabaraki, he's our pediatric neurology, Dr. Bashir, she's pediatric neurology resident, all of the other my colleague in Prince Sultan Military and Medical City. I would like to thank our audience and the organizing committee, and thank you. Yeah, as you see, Doctor, thank you. As you see, in his auntie, she had recurrent attack of hemiplegia, and they thought it's only because of stroke, as in the MRI brain. It was not explained by anything else. But as you see, we think that's under diagnosis. But if the collection of symptoms that it has sometimes with a regression of milestone, developmental delay at the beginning, and then they become fine when they grow. So usually parents forget that they were delayed at beginning. Familial case, and if it's recurrent with familial case, it is better to check for this gene. And if there's also again sensory hearing loss or migraine, plus minus migraine. In our case, there was no migraine at all, but all other distinct phenotype, they had migraine also.
Thank you.